Might be able to see better too.
What?
Might be able to see better if I can sit
Yeah,
here.
good idea.
Oh, maybe it's the weather. It's kind of like overcast or something.
Yeah, it makes me want to stay in bed. I almost
It's kind
did.
of cold out. Yeah.
Yeah, for Florida, it's a little nippy. I was gonna go swimming after this, but I think not.
Yeah.
All right, and a good little chunk of information here today. Homeostasis. Okay, so obviously for life to exist, we gotta have homeostasis, right? We gotta have it inside stay the same no matter what the outside does. Okay, so what is one method we've already talked about of keeping our blood homeostatic?
Carbon by carbon.
Woohoo, you are a winner, good job. Okay, so today we're gonna add a little bit more to our homeostasis. And of course, if we're on page 427, we're talking about the kidneys. Okay, so what else do we have to keep the same? pH. Okay, awesome. Temperature. What about our blood? Think about diabetes.
Glucose.
Glucose levels, exactly. And blood volume and blood concentration. Okay, so our major player in volume and concentration is going to be the kidneys. All right, so what do you know about the kidneys so far? Not much? Okay. They look like kidney beans, hence the name. Okay, what else do we know? The left one's higher than the right one. All right. What do they do for us? They excrete soluble waste. All right. Regulate, like we said, the plasma osmolarity, pH, and blood volume, so they can just secrete all the junk we don't need. Okay, and we said not much, so I'm guessing you don't know what hormones the kidney secretes.
No.
Okay, think of Lance Armstrong. Okay, so do you know what hormone will up your production of red blood cells?
No. Don't know anything about hormones besides the basics.
Okay,
So,
good. You're gonna learn something today. Good deal, good deal. Okay, so one hormone the kidney makes is erythropoietin. I can spell it right to be awesome, but you get the idea. So I'm not sure about that. Anyway, EPO for short. All right, and what it does is increases production of red blood cells. So this is a common thing for athletes to cheat with, right? They get erythropoietin shots, and then their red blood cells are going to go up. They can hold more oxygen. Okay, other thing that your kidney is going to do for you is make calcitrol. Okay, so what that is the active form of vitamin D. And what that does for you, you might have heard you need vitamin D so you don't get, well, you're guys, so you don't have to worry too much, but to get osteoporosis, it's helpful to get in the sun because vitamin D is going to help your intestines uptake more calcium. So calcium uptake increased. All right, what else? Kidney does another thing for you, which is, believe it or not, gluconeogenesis. What does that mean?
How your body to reverse glycolysis, right?
In this case, not exactly. You are making glucose, so in that case, it's the reverse, but you're making it from something else. So in this case, you're going to make glucose from amino acids. Questions so far? Okay, learning a lot. Okay, so here's the question today. Which is more concentrated, blood or urine?
In what sense?
Osmolarity, the total amount of soluble stuff dissolved. You would be a winner. Ding, ding, ding. Okay, awesome. So, on that note, do you know what osmolarity means? Because that's very common in the MCAT.
Yeah, like the difference in I don't know.
Okay, so 1 osmol is 1 mole of dissolved substances. So, or also known as solutes, right? Okay, and then what else we need to know? Just while we're on the topic, blood.
Sorry.
Blood's usually going to be about 300. You don't really have to know that for the MCAT, but if you do, then it's really helpful.
That's osmolarity.
Mm-hmm. But milli. Ooh, let me throw that up there. 300 milliosmoles. Okay, so in contrast, like you said, you got that concept down. Urine is going to be about 1,200 milliosmoles. All right. So now that we have some kind of idea about what the kidneys does, how do we regulate them? Well, include. Okay, the nephron's what we're regulating, and then how does the kidney know when it's supposed to dump more salt or when it's supposed to keep more water or whatever? All right, well, let's learn it right now. We're going to have ADH and aldosterone. All right, so you ever go out drinking?
Sometimes.
Okay, then you are familiar with the activity of ADH. Or if you ever play, what's that game where you drink and see who has to use the bathroom first?
No.
Okay, I forget the name of it, but ADH, it stands for anti-diuretic hormone.
Okay.
So just by the sound of that, what do you think it does? Makes you pee or makes you not pee?
Did not pee.
There you go. So when you drink alcohol, what do you suppose that does to ADH?
Deficit.
You got it. It stops the ADH, and then you have to run to the restroom. Okay, so there you go. That's what ADH does. All right, so ADH, does it act quickly or slowly? Pretty quickly, right? Okay, so by that, you can make a guess, if you don't know, would it be a peptide hormone or a steroid hormone? Nope, it would be peptide. So that's good.
Faster hormones.
So we'll go over that mechanism and you'll get that. So it acts quickly because it's a peptide. Okay, why is that? Because the peptide hormones are going to go to a receptor on the cell membrane, right? Peptide, they can't just pop through the membrane like a steroid hormone can. So they go to a cell membrane receptor, and then they're going to go to a second messenger to get their activity going, right? So something happens here, the whole mousetrap thing, right? Okay, so peptide hormones go to here, whereas steroid hormones are going to be able to just pop through the cell membrane, right? So they don't have to go to a receptor, which means they can go straight on. Sometimes they have a nuclear receptor. You've heard that before? Okay, so they go straight there, and then they actually affect the DNA. So that's why, of course, it's going to take time for the DNA to be transcribed, translated, blah, blah, blah. So it can be hours or days later. Okay, sometimes that's going to be permanent, right? So puberty, for example, permanent, steroid. So that can help you remember which is which. Okay, so aldosterone. What else do you need to know about it? Oh, where does it come from? Don't know. Okay, it comes from those little glands on top of the kidneys. If you have kidney damage, what else might you call that? You would be measuring your blank function. Okay, so renal, right? So since kidneys are called renal, what's the gland called that sits on top of the kidneys? You got it, adrenal gland. Awesome. Okay, so your adrenal gland is what is going to make aldosterone. Okay, what does it do? All right, we're going to get to the picture of the nephron on the next page. So if you want to just flip over there, you can see the collecting duct. So the collecting duct is right there. Right there. So that is where they're going to have increased solubility, right? And then that's going to mean water reabsorption. Okay, so in that case, you're going to have decreased plasma osmolarity and less urine output. Okay, so if, oh, sorry, I'm talking about ADH. Okay, so aldosterone, what's it going to do? It is secreted in response to a decrease in blood volume. All right, so it's not going to change the osmolarity of the blood.
Aldosterone?
Right. It's just going to increase salt, and then a good thing to remember for MCAT purposes is water follows salt. Mm-hmm. So if you increase the sodium, you automatically increase the volume of water just because of diffusion.
What kind of class do you normally learn from physiology or something like that?
Mm-hmm.
Sorry.
Hello. Okay. So, then ADH is our other one. That's our fast acne. And where does ADH come from?
Sister.
All right, which one?
Anterior.
All right, there you go. Good job. Okay, and then let's say that someone was taking an ACE inhibitor. What would that do? First of all, what's ACE stand for? Not familiar with it yet? All right, awesome. Learning something. Okay, so ACE is going to be angiotensin converting enzyme. Oh, sorry. We are on page 427. Okay, so an ACE inhibitor, it's going to prevent the conversion of angiotensin 1 to angiotensin 2. Okay, and how is that linked to what we were just talking about? Aldosterone is at the beginning of that. Okay, so angiotensin 2 is going to stimulate aldosterone and vasoconstriction. All right, so if this aldosterone causes vasoconstriction, and what would the ACE inhibitor be prescribed for?
Not urinate? Like not like urinate, maybe?
No.
For people with, can't remember the name. But artery hardening.
Okay, great. So high blood pressure, right?
Yeah.
So atherosclerosis is
Yeah.
what you're thinking of.
Yeah, sorry.
I hate when that happens. Okay, so vasoconstriction. Luckily, MCAT's multiple choice, so if you have that, you just look on the page and there's the word you need. Yay. Okay, so vasoconstriction is going to result in high blood pressure. So if we block the ACE, angiotensin converting enzyme, then we don't make angiotensin 2, we don't make aldosterone, and we don't have vasoconstriction. So that's just going to reduce the blood pressure by dilating the blood vessels. Okay, that's about it for aldosterone and ADH. So let's go ahead and look down to the next little step. And how do we pee? All right, we start at kidneys. And then what comes next? What goes out of the kidneys? Wait, right, left. These little tubes, right? Are going to go to the urinary bladder, and then they're going to go out this tube. I bet you know what this tube is.
Urethra.
Awesome. And these are pretty close.
Ureter.
Ureter, good job. Okay, and that, of course, is the urinary bladder. Okay.
So how did that, sorry again? What was the one after?
Okay, so it's ureters, kidney, ureters, bladder, urethra. So we're just doing the flow of urine, right? So from the kidney to the ureter to the urinary bladder where it's held until urination. Okay, so while we're on the topic, what is the forming of urine called?
Cheers.
Mixtures. All right. So we know a lot about urine, so let's go ahead and see where it is made on the next page. How is urine made? Okay. Did you know that you're a millionaire?
No.
You are a millionaire, and looking at this page, what do you suppose that you have 1,000,000 of? That are microscopic sized in your kidney.
Nephrons.
What?
Nephrons.
You got it, you got it. You are a nephron millionaire. Okay, so we're looking today at the structure of the nephron. Okay, so what does the nephron do for us? Why do we even have them? Anthony?
Functional unit of the kidney.
Mm-hmm.
It helps you pee.
Okay, there you go. Makes pee. Okay, so filtration, what's in our urine? Stuff that we don't want. So first it's all filtered out, then reabsorbed, and then the urine is secreted. So basically, if you have kidney damage, what's going to be going on there is you could have too porous of a nephron, and what would be filtered out and going into the urine that you would want to keep? Sibo, if you had a medical problem, what could you find in your urine that you don't want to be there?
Glucose.
Awesome. Glucose, diabetes, for example, should not be in urine. Okay, so Anthony, what else would you not want to see in your pee?
What?
Awesome. Blood. We do not want blood, especially there should be no cells in your urine. Okay, and what else?
Ketone bodies.
All right, awesome. Okay, how about if the urine is coming out bubbly looking? What would be in there? Not really bubbly, but it foams. Think of meringue. Ever made meringue? You're all guys. Ever eaten a meringue pie? Nope. Okay. Well, on a meringue pie, you have eggs, right? So they're all foamy. So what do eggs have a lot in them?
Protein.
There you go. So you don't want to see protein in your urine either. That's gonna look. You see a foamy look to the urine. That's indicating that it has protein in there. All right. So let's go ahead and look at the production of concentrated urine. All right, so to get concentrated urine, which of those two hormones are going to have to be at high level? ADH or aldosterone? ADH. Do you remember what
Yeah, antidiuretic.
just came in? So, but ADH is anti-diuretic hormone. Okay. So to get concentrated urine, you don't want to have a lot of water in your urine. So that would be ADH. Okay, so there you go. And about how many liters of urine are processed a day? Okay, about 180 processed a day. Well, 180 liters of blood, blood, are filtered through the kidneys. And then how much blood does a normal adult have? Anthony?
Yeah.
Did you see the,
About 180.
did you see the bombers?
Yes.
Okay, so did you see any bloody pictures? How much blood spilled out? It spreads out really thin though when you see blood all over the place. So it's going to be about 5 to 6 liters. Okay, do the math. How many times does your blood cycle through your kidneys each day? Okay, so around 30, around 30. Somewhere around 30, more or less. Of course, everybody's metabolism is a little different, but around 30 times a day, all your blood's going to be filtered out through your kidneys. Okay, so we have a beautiful picture of a kidney, of a nephron in your book. It's all stretched out though, right? So first of all, kidney is has one of your portal systems in it, and portal system you're gonna have 2 bunches of capillaries involved. All right, where's your other portal system? What organ?
Liver.
You got it. Okay, so the liver, it also does some filtration. So again, you have another portal system, hepatic portal system. Good job. All right, so here's our little picture. So we have, of course, blood coming to the kidney. So your arterioles coming to the kidney would be called what? Afferent or efferent?
To the kidneys.
Mm-hmm.
Was relative to the kidneys, right?
Mm-hmm. Afferent, awesome. So afferent arterioles are coming to the kidney. Then we have a big old mess of arteries. Not arteries. What are these little tiny things called? Thank you, capillaries. Okay, and then going out, what is this going to be called? Efferent. Good job. So just remember E for exit, right? Okay, and then what do we have around this glob of capillaries? It's in your book, right? So, what is this goofy looking thing called? Awesome, Bowman's capsule. Or you might also see it named a little more logically as, what would you call it? Oh no, the Lupa Henley's farther down the road. So you could also call it, like you said, the glomerular capsule. So I like it when they do that, name something after what it actually is. But of course, scientists want to be famous, so there you go. All right, so you have this thick part right here, starts going down, all right, And it would be all curvy and squiggly, so that's where the word convoluted comes in, right? But in your book, it's just showing you straight, so it's more simple to see the flow. So is this close to Bowman's capsule, or is it far away from Bowman's capsule? Anthony, compared to the rest of the loop and everything there.
I'm not seeing this thing on this.
You don't have that picture? Yeah, it's right here.
Yeah, but what? I'll just get over.
So this is a great convoluted tubule. So proximal, right? Means it's closer to kidney. Okay. So this is the proximal convoluted tubule, and it's called proximal because it's closest to the Bowman's capsule. Convoluted because it's all twisted up, and tubule is pretty obvious, it's a tubule. Okay, and then you see this part is thicker, then it goes and gets thinner in the descending loop of Henle. All right, then we come up. So descending, and SIBO, in contrast to descending, we have the what? Ascending. Okay, and notice it's thin throughout here. Then as we get up, back up here, we are thick again. Okay, then we come to our convoluted tubule, which again, they're just showing it straightened out in your book so it's easier to follow the pathway along. So this would be all curled up. So it's farther away from the Bowman's capsule. So Anthony, it's called what? The medical word for far away. Distal, there you go. Okay, so distal convoluted tubule. All right, now, what in the world is going on with this thin stuff at the bottom and the thick stuff at the top? Why is the tubule thicker at the top? Where would we be expecting active transport to happen? Here or here? Awesome, you got it. So this is where active transport is going on. Okay, so this is where your gradient is happening. You're trying to set up counter current multiplier. So that counter current multiplier is just a gradient of salt, right? So the gradient of salt is going to change as you go from the outer portion of the kidney. So what's the outer part of the kidney called? Sibo?
Cortex.
Awesome, the cortex. And then you're going to go down into the medulla. So the loop of Henle, the nephrons are going to be kind of spaced around, but some of them are going to be dipping down into the medulla. All right, and the concentration is going to be changing from the cortex to the medulla, and that's what's going to cause your salt to go in and out. All right, so let's look at what's happening on each little portion there. Okay, so in the proximal convoluted tubule, what is going out? Anthony.
Sodium, chlorine, water,
And what else?
amino acids, vitamins, glucose.
You got it. So all your good stuff is going out, right? Back in the old days, people had to work really hard to get their vitamins, right? Hunting, gathering, blah, blah, blah. So obviously, you don't want to pee out all of that good stuff. You want to keep it. So first, it's filtered out. And then you can see as you're going down the loop of Henle, what else is coming out? See what?
Water.
All right, and then as you get down to the bottom, you've got your salt coming out there. All right, and then as you go up to the top, that is where your active transport is going to start happening, and salt is going to be actively pumped out to maintain that gradient. All right, and then water is going to come out, and then finally down to the collecting duct, and that is where it's going to go out to the urine. Okay, so Is down here going to be more salty or less salty? In the medulla.
More.
You got it. You got it. Okay, good job. Okay, so if your loop of Henle is damaged, what's going to happen? Anthony, what would happen?
You don't lose concentration.
You won't be able to make that gradient and you won't be able to properly make your urine. Okay, questions over the kidneys? Okay, so like we said, if your kidneys are damaged, you're gonna have the good stuff showing up in the urine that you don't normally want to get rid of. Okay, so let's go ahead and go to 429 and look at our critical thinking questionnaire. What do you think will happen in a patient that has damaged glomerular capillaries that become so permeable they allow plasma proteins to enter into the renal tubule? So you're losing protein. What's that going to do to your blood? See that?
That's going to be hypoosmotic. It's a non-available protein demand.
Okay, you got it.
Should be less concentrated.
You got it. You got it. Okay, so what would that do to your body? How will you see that if a patient comes in with that problem? What would they look like? So basically, you have a lot of water in your blood, right? So where is that excess water going to be going? Out, right? It's going to go out your capillaries into your interstitial spaces. And whoop, you're going to be puffed up, and what is that called?
I don't know.
Edema. Okay, so you're taking massive amounts of water this way. It could be like 300 pounds just from excess water. Nightmare. All right. What else are we? Okay, here's a good little question here. I think you guys will get this one. So diuretics like caffeine cause a decrease in water reabsorption, resulting in an increase in urine volume. So go ahead and design an experiment to determine if caffeine is blocking the ADH receptors or does it prevent ADH release. Okay, so all you're going to do is measure the urine volume, and you can give ADH and caffeine. So take a minute to think about that and see what you can come up with to determine whether ADH blocks receptors or prevents, whether caffeine blocks receptors or prevents ADH release. What did you come up with, Saber?
So one replica with caffeine only, another with ADH only, and another with ADH
Okay, awesome. So, how are we going to evaluate the results?
Urine volume. See, so we compare the ADH plus caffeine trial to the ADH only trial to see if there's any change.
Okay, so if there's a change, what does that mean?
Um, if there's a decrease in urine volume or an increase in urine volume, what do you know, ADH, a decrease in urine volume or more concentrated urine, right? That means that caffeine is going to block the receptors.
If the ADH changes it? If giving ADH changes it, you're saying it would block the receptors?
Oh, okay, sorry, no. It would block the release.
Good job,
of the
good job,
body's
good job.
ADH.
You got it. Okay, so if the receptors were blocked, giving more ADH wouldn't do anything because there'd be no way for the ADH to act if the caffeine was blocking the receptors. All right. Okay, so our next little topic here, still thinking about homeostasis. Obviously, one thing we've got to regulate is our temperature. All right, so we have a cute little chart there. And Anthony, where on that chart, why do we have two peaks? Why do we have a peak in metabolic rate when you're cold and then a peak in metabolic rate when you're hot? So what's actually going on in your body is what I'm asking. That is causing you to expend more energy. You got it. Exactly. So just trying to sweat or shiver like that. All right, and then what happens with your blood to control your temperature? See that? Your blood vessels. Okay, there you go. So when it dilates, that's going to make you.
Colder, you're gonna lose more heat.
There you go. Exactly. So, like when you think about frostbite, for example, your body's trying to keep your core temperature warm, but then you're going to end up shutting off the blood to your fingers, and then bonk, you have no fingers. I hate when that happens. Okay. Any questions over temperature regulation, ADH, aldosterone, ACE inhibitors? All right, let's go ahead and talk about hormones. Okay, who is the master of hormone regulation? What organ in your body? The hypothalamus. There you go. Okay, so the hypothalamus is going to regulate which part of your pituitary?
Sure.
Anterior. There you go. All right, so hypothalamus controls the secretion of your tropic hormones. All right, let's look at a cute little mnemonic for those tropic hormones, or more hormones. Okay, so here's a mnemonic, and the MCAT definitely expects you to know these hormones, how they're regulated, and what they do. All right, so these are tropic hormones. In other words, they regulate other things. Okay, and these are direct acting. All right, so let's see if we can figure out what these hormones do. So, Siva, what would the F stand for?
Follicle stimulating hormone.
Awesome, follicle stimulating hormone. And what does that do?
Stimulates ovulation.
And what else? Think about men.
Sperm production.
There you go. So FSH, it's going to stimulate spermatogenesis in men and the maturation of ovarian follicles in women. Okay, so Ovarian follicle maturation. And spermatogenesis. All right, and then how about L? Anthony, what would L stand for?
Like, I don't really know much of this stuff at all.
Okay, all right. I want to ask you then. Okay, so SIBO, what's L stand for? All right, luteinizing hormone. Okay, and I forgot to ask you, how is FSH regulated?
Gonadotropin, regulating hormone.
Releasing.
Regulating hormone. Releasing, yeah.
And then that in turn regulates female hormone.
That's true.
Well, it's in male too, but you know. Okay, so gonadotropin releasing hormone, estrogen, those regulate FSH. Okay, and then LH is luteinizing hormone. Okay, so luteinizing hormone is regulated by what? Think in terms of the menstrual cycle, it might help you.
Whatever the blue one is.
Got erased. Estrogen.
That's true.
Okay, so estrogen, and I don't suppose either of you have ever taken the pill.
Progesterone.
You got it, good job. Okay, so estrogen and progesterone. Okay, and again, what regulates those?
GnRH.
Gonadotropin releasing hormone. Okay, and then we just talked about the gland on top of the kidney, right? So this is going to be made in that, I lied, it's not going to be made there, it's going to be made in the adrenal cortex. Yeah, that's right. So adrenal cortex, so the outside part of the adrenal gland. So ATCH stands for adrenal corticotropic hormone. All right, so that's made in the adrenal cortex, and what does it, I'm sorry, it's not made in the adrenal cortex. Oh, it's made in the anterior pituitary. And then it goes to the adrenal cortex and makes corticosteroids. Okay, and then we have one more in the tropic hormones, which is TSH. Might have heard of that. Okay, Siva, do you know what TSH stands for?
Thyroid stimulating hormone.
Awesome, thyroid stimulating hormone, also known as TSH. Okay, so thyroid stimulating hormone, it's going to act on the thyroid to absorb iodine and then release thyroid hormones. So iodine is basically converted into T4 and T3. Okay, and if you're ever going to be like an endocrinologist, it's important to know that when you're talking about thyroid hormones, it's important to measure both of these. Sometimes you can have a problem here and have thyroid dysfunction, even though this will be normal. All right, now let's look at our direct hormones. Okay, P, what do you call it when you have a problem with milk? You are blank intolerant. Okay, lactose. So P stands for prolactin. All right, so can you guess what it does?
lacting that you use.
Think of the ladies with babies.
Oh, okay.
It's going
Stimulate
to.
milk.
You got it. You got it. Okay, so prolactin is actually stimulating milk production, and then oxytocin. It's not on this, but oxytocin is actually stimulating milk letdown. Okay, so.
Will that also have to do with the maternal love feelings and all that stuff?
Exactly. Have you ever had a cat?
No.
Okay, well, you might not relate to this, but cats do this annoying thing where they go and like paw you. So that's one way of stimulating the mother to release milk. They're like, relax, mom. They make the oxytocin, or I'm not sure if cats have it, but something similar, and then the milk is let down. Okay, so babies, you get the same feeling from babies. All right, and then we're gonna talk next about E. E stands for, you got two choices. I didn't ask you. I'll ask you the harder one. Endorphins. Or do you know the more medical sounding name for that?
Capillaries?
Awesome. Maybe I could spell it right. Okay, so those are just gonna block the sensation of pain. Okay, and finally, G. Anthony, by looking at me, you might not think that I had a lot of this as a kid. You got it. Okay, so G is for growth hormone. Okay, and what does it do? Sibo, what does growth hormone do for us?
Makes you grow.
Okay, makes you grow. And specifically, what does it make grow?
The bone.
Bones, and what's on the bones?
Muscle.
There you go. Okay, so bone and muscle growth, uptake of glucose by some cells. Okay, what else? If you don't have it, what does that mean? Dwarfism. If you have too much, gigantism. All right, let's see. Okay, so what other things do we have that are making hormones? Pancreas. Okay, I bet you happen to know this just from life. What does the pancreas make? And you're missing it if you're diabetic.
Insulin.
You got it. Okay, so Sibo, where is insulin made in the pancreas?
It's electrons.
Okay, and can we get a little more specific?
Beta cells.
You are awesome. Okay, so beta cells make insulin. Okay, so what do alpha cells mean? Glucagon. Outstanding. All right, so there you go. Insulin is going to let glucose be taken up into cells. Okay, so we have specific receptors on cells that are going to be activated to take in glucose by insulin. Okay, and then what does glucagon do?
Stimulates glucose production from glycogen.
You got it. Okay, thyroid. What does thyroid hormone do?
Is it involved in adipogenesis?
That is a darn good question that I'll have to get back to, but you don't have to know that for the MCAT. It stimulates calcitonin. Okay?
Which hormone was this?
Thyroid, or what thyroid does. So calcitonin, my little mnemonic is it tones the bones. Okay, so it's gonna take the calcium out of your blood and put it into your bones. Okay, so from the blood, so it's lowering your blood calcium, and then it's increasing the calcium in your bones. And it stimulates your osteo what build bones?
Blasts.
Osteoblasts build. All right. And then what else? Okay, so parathyroid produces what hormone? It's a really straightforward one. Anthony, what do you suppose parathyroid glands produce? Don't even think about it. Just dead obvious. Parathyroid gland produces parathyroid hormone. There you go. I love when they make easy ones like that, right? Not a lot to remember. So parathyroid glands makes parathyroid hormone. Okay, so that's going to be acting opposite to calcitonin. So, Anthony, if calcitonin takes calcium from the blood and puts it in your bones, what does parathyroid hormone do?
The opposite.
So it takes it from the bones and puts it in your blood. Okay. Glucocorticoids. Okay, what's made in the adrenal gland? See what?
Corticosteroids.
Okay, awesome. And let's break it down. What do corticosteroids do?
Stimulate the sympathetic nervous system.
No. Well, sort of. Somewhat. Well, I'm sorry, I didn't hear what you said. You said corticosteroids. Okay, you're right. So let's break that down. That has a little more divisions in there. So what specific corticosteroids stimulate the sympathetic nervous system?
Epinephrine.
There you go. Okay, so epinephrine, norepinephrine. Norepinephrine, epinephrine, they are going to stimulate fight or flight response in the sympathetic nervous system. Okay, then we have some other corticosteroids. So we have glucocorticosteroids. That's a long word. And that does what? Regulates glucose.
Glucocorticoids also play a role in like anxiety and
Exactly. So anxiety causes production of what? It causes you to get a tummy, damn it. Okay, so when you get stressed out, when you're working 20 kabillion jobs and you just want to kill someone, cortisol is going to regulate, it's going to be involved in regulating your glucose. So it's going to try to raise your glucose levels so you can deal with the stress, right? But unfortunately, in the modern world, when you have stress, it doesn't necessarily mean you're exercising. So being stressed out a lot can make you end up with gaining weight. Okay, and it's usually around the middle area because those are the cells that are more sensitive. Okay, and what else? Cortisone. Okay, so those two hormones are going to regulate glucose. Okay, and you already mentioned epinephrine, norepinephrine. They're made in the adrenal cortex. ATCH stimulates them. Okay, then we have one more class of corticosteroids. Vitamins and things that you need to take. Vitamins and, no? Mineral corticoids. Okay, and what do those regulate? I'll give you an example that we just talked about. ADH is one. I'm sorry, not ADH. Whoop. Aldosterone is one.
Salt balance.
Exactly, salt and water. Okay, so aldosterone is made in the adrenal cortex, and it's a mineral corticoid, and it regulates salt and water. Okay, so one thing favorite on the MCAT is hyper and hypothyroidism. What would cause that? So what's going to happen if you have hyperthyroidism?
You're going to produce a lot of calcitonin.
That too, and also you're going to produce the thyroid hormones, which is going to increase your metabolic rate. You're going to end up probably being really skinny and hyper and dry. Okay, questions of those? All right, let's flip on over to page 431 and talk a bit about some more glands. Okay, so we already talked about the adrenal glands. They make your corticosteroids. So mineral corticoid, glucocorticoid, and your endorphins, basically. Norepinephrine and epinephrine. Okay, so what do the testes produce? What's a suffix or prefix that means man? Mm-hmm. So they produce androgen. Okay, and what is a prime example of androgen that is produced in men? Hormone. That's the hormone that stimulates sperm, actually. And
Testosterone.
there you go. So testosterone. And you've already experienced the effects of testosterone, right? Puberty, deep voice, facial hair, blah, 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 muscle growth. Okay, so what do the ovaries produce?
Wait, don't testes also produce trace levels of estrogen too?
Mm-hmm.
Not trace levels, but most.
Yeah. And we're gonna look at an example of that in a little bit. Okay, so ovaries,
Estrogen.
estrogen, and what else?
progesterone.
Mm-hmm. Good job. All right, excellent. So, what does progesterone do for a woman?
Maintains the uterine lining.
You got it. Maintains your uterine lining. Okay, so in preparation for implantation of a,
Embryo.
there you go. Okay, and then of course estrogen turns you into a woman, right? So that can also happen to guys, and that's glad you brought that up because we have that next. So estrogen can also affect men and have them producing female secondary sex characteristics. All right. And we have a little extras on the next page that's going to deal with that. Okay, and then let's go ahead and look at glucose regulation. All right, so high glucose, that's what goes in that first blank there. High glucose and insulin, high insulin, what is that going to do? If you have insulin and you have glucose, where does the glucose go? It goes into your tissues, into your cells. So, and then what happens to the glucose levels? In the blood glucose levels. I'm sorry, I didn't hear you. Yeah, so your blood glucose goes down. All right, so in the next one, we have low glucose in the blood. And then we're going to go ahead and make some glucagon. Which, Anthony, what does glucagon do?
Break down glycogen.
You got it. Breaks down glycogen. So what is that going to do to your blood sugar?
Increase.
You got it. Increase your blood glucose. Okay, what am I supposed to talk about this? All right, so if your body does not produce enough insulin because your beta cells are damaged, let's go with that one first. If your body doesn't produce enough insulin because your beta cells are damaged by autoimmune response, Siva, what disease does that give you?
Type 2 diabetes.
Type 1. You can remember it because type 1 used to be called juvenile diabetes, so that would come first, right? So type 1 used to be called juvenile. But unfortunately, a lot of little kids are getting type 2 now because they're so fat. So juvenile diabetes isn't used that frequently as it used to be. So type 1 diabetes is generally caused by autoimmune response and destruction of the beta cells. All right. Then what's going to happen to your blood glucose? Anthony? You have type 1 diabetes.
It's gonna be high, right?
It's going to be sky high. 600, 800, coma, death. Bad things. Okay, so then how about type 2? What is type 2 diabetes caused by? See that?
Lack of insulin receptors.
So lack of sensitivity. And then eventually the pancreas really struggles and you can lose some beta cell function as well. Okay, so type 2 Initially is thought to be caused by low expression of insulin receptors. All right, so there's that. And then, what is diabetes insipidus?
Those two are diabetes mellitus, right?
Mm-hmm. Mellitus is sugar. Lord have mercy. Luckily, you don't have to spell on the MCAT. Insipidus. I think that's right.
Easy points.
Huh?
Easy points.
Not for me. I love some multiple choice. That is the beauty of the MCAT. I know the word, but I'm like, that looks funny. I think it's right. Anyway, diabetes insipidus. It is going to be. Anyone not familiar with it? Okay, diabetes insipidus can be caused by a lot of different things. All right, it is caused by lack of ADH. And Anthony and I were just talking about if you have a few drinks, I don't know what your habits are, if you have a few drinks, what happens to you quickly? There you go. So alcohol is going to block the ADH. Okay, so diabetes insipidus, it's either going to be due to lack of ADH production, it can be due to brain damage. So if you suspect diabetes insipidus, you should actually get a brain scan and see if it's due to an organic problem. Have you been bashed in the head and your hypothalamus is going crazy? Okay, or so lack of ADH, or of course lack of ADH receptors. Okay, so diabetes insipidus, obviously you're running to the bathroom a lot, so what else is going to be another symptom? You're going to be wanting to drink a lot, so polyuria and drinking a lot.
Drinking alcohol or drinking?
Oh no, water.
Don't like some people
Alcohol
that drink a
would-
lot get diabetes. That affect alcoholism. Have you heard about that before?
There seems to be a connection.
Yeah.
I don't know if it's the diabetes that causes the alcoholism, though. It's like a correlation than a causation. So I don't think that's firmly established yet. All right, so questions about glucose, diabetes, glucagon, other? Any questions? Okay, so let's go ahead and talk about the menstrual cycle. All right, so what happens in the menstrual cycle? Did I erase any of that? I still have everything I have. All right, here's the menstrual cycle. So it's a cycle, so I don't know really where they decided that the beginning would be the beginning, but at any case, generally medical books consider the beginning to be where you have low estrogen, low progesterone. Okay, so if estrogen is low, estrogen normally does what to gonadotropin releasing hormone, SIBO.
If estrogen is low,
Oops, I saw the answer. What is estrogen? Yeah, if estrogen is low,
then
well,
there's going to be more GnRH.
there you go. So if it's high, it's going to be inhibiting the gonadotropin releasing hormone. Okay, so next step, what does the gonadotropin releasing hormone do for us? Not for you, but for me. It is going to act where? Anthony, where does the gonadotropin releasing hormone act? A little more specific in there. Oh no. Gonads are.
I never even heard that word.
Okay, so the anterior pituitary. Okay, it's going to act on the anterior pituitary. And remember, we just looked at all those hormones that come from there. And one of those was follicle stimulating hormone. So gonadotropin releasing hormone goes to the anterior pituitary, and it's going to release follicle stimulating hormone. Okay, so as you probably know, women are born with all the little eggs that they're going to have, right, are in the ovaries. So the FSH is going to go ahead and allow just one ovarian follicle to grow. Okay, so SIBO, what does the follicle produce?
Eggs.
It is the egg, right? Well, I mean,
Oh. Well,
not is, but you know, you're right, but what hormone? Let me be more specific. What hormone does the follicle produce?
luteinizing hormone? Oh, estrogen.
Estrogen. And then the estrogen is going to go to the hypothalamus. So, but you're right, just not on this step. So later on, it's a different pathway. The FSH is going to stimulate the LH. You're right about that. So keep that in your brain. The FSH is going to stimulate the luteinizing hormone spike. Okay, so what's going on here? Where are we on this graph? So here we get a peak of estrogen, and then we get, like you said, luteinizing hormone. So estrogen goes to FSH, FSH goes to LH. Okay, so then when your LH spikes, the follicle burst, might have pain in your side. Anybody know what the word for that pain is?
The, what people always say it is, or the official?
The official word. Okay, so this is not cramps. This is a pain during ovulation. It's called Mittelschmerz, which just means middle of the cycle, middle pain. So Mittelschmerz is when the follicle bursts, it's actually painful. Just gonna throw a fact out. I lived with my dad during this age. Did not know what that pain was. Always thought I was dying. So if you have any patients that are about that age, young age, just let them know. That's just Mittelschmerz. You're not gonna die from that.
Is it different from cramps or this what
Yes,
it is?
different.
Okay.
This is during ovulation. So cramps are down here when you're shedding the lining of the endometrial lining. So all in all, you have about 2 good weeks of life. No. Okay, and I'm gonna throw out a pet peeve here. Just because I don't want you guys to be doctors and just not be aware. Okay, so during this stage, obviously you're losing a lot of what? That's in the blood. Not hormones, but in the red blood cells specifically.
Iron.
Iron, there you go. So if you have patients coming in and they're like, I'm so fatigued and grumpy and bitchy, don't give them a freaking antidepressant. Tell them that, they might need to let their iron levels be checked. Okay, because that really happened to me a lot. I'm like, I'm so fatigued, I feel terrible. They're like, here, take these happy pills. Okay, and not until very much later in life did someone actually get me to take an iron test.
You had a terrible doctor.
A lot of terrible doctors. Okay, because I didn't make the connection because I was feeling horrible already. I'm like, I'm so tired, I can't even think. So,
How much
all right.
iron can you just take like a multivitamin and it'll
Yes, you can take just a little pill, and then you are no longer feeling like you're gonna die. I could just strangle some doctors. Okay, so sorry, personal pet peeve there. Don't do that. All right, so back to the MCAT, though. You might need to know that for the MCAT as well. Okay, so passing this test. All right, what else do we need to know? Fertilization versus non-fertilization. Okay, so we got down to this step where the follicle burst out, then it's gonna make the secondary oocyte and when that's released, it leaves behind the corpus luteum, dead body. The corpus luteum is actually going to be producing hormones as well. So the corpus luteum produces estrogen and progesterone. All right, so with progesterone, it's going to go ahead and, of course, thicken the endometrial lining and get prepared to implant an embryo if there is fertilization. Okay, so if there's not fertilization, what happens? Oh, I left something out. What does the embryo produce that can be picked up in a pregnancy test? Just throwing stuff everywhere. What? You've never taken a pregnancy test? Okay, so you've seen those shows though, right? Like, I didn't even know I was pregnant, right? Okay, so how is that possible? We have the embryo. It's gonna be producing HCG. And what does that stand for? Human.
Orion.
Mm-hmm. It just gave me a moment, but human chorion something. Anyway, it is what is going to let the embryo signify that I'm here, and it's going to produce progesterone and estrogen. So this hormone is going to maintain the corpus luteum. Okay, so then, obviously if there is no fertilization, then the corpus luteum is not going to be making the progesterone and estrogen. Okay, and then if those are not going to be made, what's going to happen to okay, what's going to happen to the endometrial lining?
It's going to be shed.
Yeah, it's going to be shed, and here is where the cramps issue is, right here, well, anyway, this picture, sorry, I just copied it, but it would be right here. End of the cycle. All right, so as we were saying, looking at this, eventually the, what is the thing around the baby called? Amniotic fluid, but then what's the, like, it comes out after the baby is born?
Placenta.
Yeah, there you go. Okay, so the placenta is going to take over the role of making progesterone and estrogen once the embryo is developed to a sufficient degree. So then the HCG is not going to be made anymore. Okay, so how could someone actually seem to be as retarded enough to think they weren't pregnant? Right? They could actually get a false pregnancy test, right? They could get a false negative because if they didn't read the directions and they waited too late, right? They were in denial for the first few months or whatever, then they could find that there is no HCG because that's what most pregnancy tests measure. So if the embryo is no longer making HCG, the pregnancy test is going to show that they're not pregnant. Even though by that point I think it should be rather obvious, but still, by that point you could get a false negative. Okay, so we already mentioned what's in birth control. So Anthony, what's in birth control pills?
No, it makes it so the egg can't stick to the uterine wall.
Okay, and what are the two hormones that keep the uterine lining nice and fluffy? Estrogen and progesterone. So that is what is in birth control pills. So they're actually going to prevent ovulation because your body's going to think that you're already pregnant. Okay, so let's look down at number 1 there, critical thinking exercise. Which of the following graphs represents the level of luteinizing hormone during the menstrual cycle? Okay, Siva, what do you think?
C.
Okay, good job. Okay, Anthony, what does A represent? Oh, here it is. It's the black one on the board.
FSH.
Uh-huh. Okay, and then what does B represent?
Estrogen.
And D. All right, there we go. Okay, so that you definitely need to know for the MCAT. Very common. Okay, let's talk about how do these hormones actually work. All right, so moving over to page 433. All right, we are comparing and contrasting steroid hormones and peptide or amino acid hormones. Okay, so our first thing there is the precursor. In other words, what are we making these hormones out of? So, Siva, what is a precursor to steroid hormones?
Carbohydrates.
It has a double ring, or not double,
Cholesterol.
there you go. Cholesterol. Has how many rings in it?
5.
There you go. Okay, so you're going to take that 5-ring structure cholesterol and just add little molecules onto it, and then you're going to make your steroid hormones. So steroid precursor is cholesterol. Cholesterol. All right, and then obviously peptide hormones are made out of what? There you go. Amino acids. Good job. Okay. Permeability. We're talking about the cell membrane. Are they going to pop through the cell membrane, or do they have to go in through a receptor? Okay, so Siva, how about the permeability of steroid hormones?
Fat soluble. So permeable.
Okay. And proteins are not. Amino acids are generally polar, so non-permeable. Okay, and then transportation, we're talking transportation through the blood. How are steroid hormones transported through the blood? Awesome. They have got to be bound to carrier proteins. All right, and then how about peptides?
They can just dissolve in the blood, right?
You got it. Dissolved in the plasma. Okay, and then next we're looking at what receptors do they go to?
Nuclear.
Wait, which one is which?
Steroids are nuclear.
Okay, nuclear or it could be cytoplasmic. Good lord, nuclear or cytoplasmic. Okay, and then Siva, where do peptide hormones have receptors?
Extracellular membrane.
Awesome. Okay, and then next we have our action. What do they do? And that's pretty easy to derive once you know their receptors, right? So, Anthony, where do the steroid hormones act?
On the DNA transcription.
You got it. They bind to DNA. And that being, they're going to either turn on or off genes. Okay, so SIBO, being that peptides act on the cell membrane, how do they act?
Cell signaling.
Great. So signaling, second messengers, and what do they act upon in that case?
Well, they could also act on the DNA or other organelles.
Usually they're going to either turn on or off protein synthesis. All right, looking good. And then our next little thing is the duration. How long do they last?
What's onset?
Oh, oops, I skipped that, sorry. Okay, so onset, meaning how fast do they take to act?
Well,
There you go, hours or days. Or months, if you're talking puberty, right? Okay, and then peptide. Those are very fast. So seconds to minutes. Which of course makes sense because this has to go all the way through transcription, translation, et cetera, and this just quickly stops the proteins. Okay, and then duration. Okay, Anthony, how long do steroids hormones last?
For a long time.
So again, hours or days. And then, SIBO, how long do amino acids last?